I will introduce him. Dr. David Woodrum is a professor of pediatrics, senior member of the Division of Neonatology in the Department of Pediatrics at the University of Washington, a mentor of mine and I'm sure of many others here today. He's a consultant and member of the attending staff of Seattle Children's Hospital, a member of the Truman Katz Center for Pediatric Bioethics, and a faculty associate in the Department of Bioethics and Humanities at the University of Washington. And he told me as he was walking to this panel, he said, now I know the title of what I do, I'm a fetal pediatrician. So with that introduction, I think, Norm, you wanted to say something quickly before we field questions, but I would invite anybody who has questions to make their way to the microphones in the center of the aisle. If you can't do so, just indicate that to us and we'll try to get a microphone to you. Norm.
Thank you. Is this on? Can
Yes.
you hear? I just wanted to make some comments on my friend Mark Mercurio's wonderful talk, to give again a slightly different perspective, or at least move the needle a little bit from where Mark left it at the end. So Mark, number one, acknowledged that at least there might be serious ethical problems with a pregnant woman making decisions that were going to lead to high likelihood of serious harm to a future child. And let me just emphasize, I'm not going to say anything about fetuses. I'm going to just stipulate for the moment, let's say that a fetus has no moral status at all, just for the sake of discussion. So this is entirely a comment about future children, that is a situation in which it's highly likely that a child's going to be born, somebody who is entitled to protection and who can only be protected by intervening prenatally. Number one, if there's a serious ethical problem, as Mark acknowledged, there's a notion in the law that where there's a wrong, there ought to be a remedy. If there's a serious ethical problem, then there ought to be some, that is, if it's seriously wrong to behave in a way that leads to harm to future children, there ought to be something to reduce the risk of that harm. Point one. Point two, when other people behave in ways that fetuses are damaged in a way that exposes a future child to harm, we have lots of remedies. That is, when doctors misbehave and do something that doesn't harm the fetus but harms the future child, he or she is subject to harsh penalties. There are criminal penalties for people who assault women and do things that lead to future harm. To take an old philosophic example, if somebody puts a bomb in a schoolyard and sets it to go off in 20 years, we don't say, oh, well, it doesn't harm the interests of any present people, that only harms the interests of people who aren't even conceived yet, so we can't be worried about that. No, we don't say that. We lock them up and we put them in jail for exposing future possible people to harm. So the issue is whether being pregnant should somehow give you immunity against what, and everywhere else in society, for doctors, men, schoolyard bombers, I'm not equating pregnant women with schoolyard bombers, but that if we do agree that it's appropriate to protect future children from harms, I don't know why pregnancy should give you some immunity on that front in the legal domain. Second point, I think Mark gave it, maybe for interest of time, only gave a limited list of some of the legal cases. So there have been court-ordered C-sections, at least a couple dozen of them, and most of them, courts have ordered them. He mentioned the AC case, in which was a very complicated case in which the federal court said it was wrong to have done it. But there are two state Supreme Courts in Georgia and Colorado that upheld for C-sections under very questionable circumstances. There is racial discrimination in these kinds of cases, as there are in most of our legal system. But discrimination is not a reason to say, oh, well, we're just going to abandon the field. That is just because blacks go to jail more disproportionately than whites for violent crimes or drug crimes doesn't mean, oh, therefore we're going to suspend all our statutes in those areas. We try to, the point would be to be more just. So in the interest of time, I'll shut up. But there are other areas of the law in which we take cognizance of harms to future children. It's got nothing to do with fetal rights. And I don't know, as a matter of at least law, why pregnancy should confer immunity.
Mark? Well, I'll give Mark a minute, and maybe you.
I just need 15 seconds, and I'm just going to keep moving the ball because I think Norm makes an excellent point, and it's worthy of discussion for the group. I actually wanted to touch then. I'll take that and say touch on something that Elena said about that's right, which I think is good. And I'll take it even further. It's something that I was mentioning to Jeff just before the conference talked about it. Before the conference, I was saying there was this terrific article that came out of Harvard a few years ago about how the American Academy of Pediatrics and the American College of Obstetrics and Gynecology had the difference between their two policy statements with regard to maternal-fetal conflict. And I was explaining this to my friend Jeff, trying to help the kid along, teach him a few things. And, as it happens, Jeff's the author of the paper. Live and learn. But it's an excellent paper that makes the point that I think you were touching on, Elena, about how that when you get the pediatrician involved, it is a slightly different point of view. There's no question about it. And as demonstrated by our different policies, which are about 96% the same, but slightly different. And so I think that Elena's point was interesting, and Jeff's had a wonderful paper that demonstrated that point.
And those policies actually have been different for a long time. What was it? I won't say how many years ago. You were the chair of the AAP committee when I was the chair of the ACOG committee, and we had the same conversation about, well, there must be some case under which it would be okay to get a court order. And I think your language was wonderful. We can't imagine what it would be, but theoretically it's out there. I'd like to make one other point about the fact of pregnancy. And I think your immunity question is a good one. Legal immunity is a very high bar. But I do think that when a woman's pregnant and the fetus is inside of her, one does need to respect her need to balance a lot of different obligations that she has. And the fetal well-being can't trump the rest of what she has going on in her life. And one example that one hears is, for example, if there were a medication that she needed to take in order to prevent some serious disability in her future child, and it was really expensive, and we hadn't had Obama curing the healthcare system, she couldn't afford it. Either she feeds her 3 children, or she pays for this pill that's going to save her 4th. She's going to need to weigh that, and he's going to have some. We probably should let the poor people start asking more questions.
Yeah,
There are no absolutes here.
So let's start taking questions, and we can continue the discussion. Jonathan.
Hi, John Fanneroff from Cleveland. Is this on? Hello? Oh, all right.
There you go.
Hi, John Fanneroff from Cleveland. I enjoyed the presentation again, and this is directed towards Mark, but I'd also love to hear from the OBs. You talked very well about sort of the 4 cornerstone principles of bioethics, autonomy, justice, and so forth. But the other thing we use a lot in ethics is talk about benefits versus burdens. And I don't think there's any question in the forced C-section example that that's a very significant burden on the mom under any circumstance. But there are other situations, and the one that our NICU tends to be filled with is babies from drug-abusing mothers, where saying that a mom should avoid drug use, illicit drug use, during pregnancy may not be as much of a quote-unquote burden on her. And yet this is also a very large ethical dilemma that we have. So I don't, and I know that there are situations where, and once again, this tends to be poor minorities where, where women are put in jail so that they won't use drug use or other things that are also be a significant burden. But I'm just wondering about your perspective on the ethical analysis of the burdens on the mom of avoiding drugs, even though she wants to use them.
Well, I'm sorry. I apologize, Norm. Was that question for me, Norm, or just in general for us?
Well, you just started, yes.
You want to go first, Norm? Well, just very quickly, it's an excellent point, John. With regard to illegal drug use and addiction, the adage which you know well, and I'm sure many people in the room know well, that ought implies can, which is to say that a heroin addict is obligated not to use heroin, is to suggest that that's something she can do. Now, certainly she can get methadone, et cetera, but you get my point. With addiction is a bit of a difficult case because it's not a totally voluntary behavior commonly. Moreover, I think that I would tend to agree with those, including Harris, and those who lean more toward the maternal-fetal relations, that we're going to get more mileage. There's going to be more, in the end, we're going to do better for the babies and the moms if we work on a preventative approach rather than a punitive approach with regard to many of these things. And we certainly don't want to do things that are actually going to drive people away from prenatal care, which is the other fear. But your point is well taken. I used the extreme case of the C-section. It becomes a much murkier, all the way down to the Connecticut cream, to make the point that that's the far end of the spectrum, but that it becomes murkier. But I do think addiction is a special case.
Yeah, obviously benefits and burdens do matter, and there are some non-hypothetical cases that might come closer to meeting respect for that point. So, for example, there's some controversy now about fetuses that have a form of virilizing adrenal hyperplasia, that is, have disorders of the adrenal gland in which simple oral cortisone, or a cortisone-type drug by the mother, will avert a cascade of events that will cause malformations in the baby. So all the mother is being asked to take there is a medicine which is very minimal risks to her and can have major benefits. So that's one case in which we're not talking about operating on people. Another, to respond to Elena's comments, was a case in Michigan some decades ago in which a woman took tetracycline for a somewhat unnecessary reason. That is, there were other antibiotics that would have worked, and knowingly took tetracycline, which, by the way, causes severe staining of the permanent teeth of newborns. So her baby, who sued her, was born because she, quote, took away my smile, end quote. That is, brown teeth, which were very hard to fix. And there was a somewhat trivial reason for her to take this tetracycline. It's a much more complicated case, but in there the courts upheld the claim that, at least, I should put it differently, the courts rejected the notion that there was some sort of immunity, that a child could not sue his mother for something she did prenatally. And I would just put it in moral terms slightly differently than Mark did. If a child winds up being severely, let's say, brain damaged for something that the mother could have easily prevented, it may be surgery, it may be medicine, but something that is a standard medical practice and not extremely risky. And the child at age 3, 5, or 7 who's permanently disabled and asks, who did this to me? And how did this happen? And where was everybody else? And was I not entitled to any protection? I think it's not only a poignant moral claim by the child, but I think it's something that calls for some kind of a remedy in cases in which the facts are relatively low risk for the mother, high likelihood of serious harm to the child, high likelihood of benefit, standard practice, something any reasonable person would do.
May I just ask one little follow-up? You don't need to answer this because I'm not sure there's an answer, but the criteria that you just listed, you know, high likelihood of success, standard practice, low risk, I don't think we can think of many medical interventions.
I just named one, dexamethasone for virilizing adrenal.
I just remember reading something about a controversy over that, actually. So, anyway.
I guess, setting the ethics aside, I'd say as a practical matter, I'd make 2 points. The lower the burden and the more certain we are of benefit, the easier it should be to convince someone to go ahead and take the dex or take the steroids or do what we want them to do. And if they're not, then we need to examine our assumptions. And with regard to drug treatment specifically, I don't know how many of you have tried to get a pregnant woman into a drug treatment program. And it may be easier out here than it is where I come from, but it's near about impossible. And so I regularly see people that say, boy, I'd like to do something about my cocaine, heroin. You fill it in, and then you spend forever. So we can also work to reduce the burden, on our side.
Okay, why don't we take the next question?
Gary Pettit from Kansas City. As the late Bill Silverman used to say on occasion after occasion, neonatology's had a very checkered history with unproven, innovative interventions based on intuition. As I listened to our last presentation here, which I enjoyed very much, the question that came to my mind is this deja vu all over again? And have neither we nor our professional organizations learned anything from history?
I think you're referring to fetal surgery.
Yes, I was talking the fetal health centers and the litany of lists of things that we can now fix.
It's been, I think, really interesting, even in an academic medical center with a lot of research, how challenging it has been to convert these attempts into clinical trials or even controlled cohort studies. And I don't have the answer for it, but I share your concern.
Well, it seemed to me at least places like the Academy, Pediatrics, and ACOG could take some sort of reasoned stance as these things are rolled out, which seem to be largely for economic and institutional competitive reasons.
Sure. I mean, I've been part of a couple of ACOG committees, and perhaps not as directly as you've liked, but we've looked specifically at kind of what we term the maternal-fetal relationship and how fetal surgery does or does not fit into that and potential for abuse. And then separately, we've also looked at the issue of innovation in medicine in general and how it should be appropriately studied, and argued with fetal surgery specifically that it is an experimental treatment and needs to be studied as such with the appropriate controls and under the auspices of an IRB, and it's not simply the same as a slight tweak of something that's accepted with certain benefits. Maybe not as direct a response as you'd like, but people are focused on it a little bit.
I'm not sure that we have a hook to really make it happen. It's sort of the same issue we have with how many embryos do you transfer back to a woman in IVF when she says to you, these are my embryos, how dare you keep me from having them all? If we had a single payer health system in our country, we might have an economic way of putting the brakes on some of this.
And Elena alluded to some of the challenges in organizing the mom's trial, the meningomyelocele trial, and she's very much was and still is part of it, and I won't ask her to betray anything, but part of the challenge there was what's to keep a center from saying, we believe in this, we're just going to start offering it. And in this day and age, now all you have to do is Google, and if you're you're a desperate patient or parent, you can then go to that center and just get it. And where is the hook or the stick to keep some center from not doing that? And so, I mean, that's part of the challenge of organizing the trials here, is you have folks in desperate situations, and you have true believers who, with the best of intentions, really believe they're offering help.
Could I just say, I mean, this is not unique to fetal surgery. This is a medicine, right?
Sure.
And this is where I don't mean to play into stereotypes, but I'll play into it a little bit. I would just say that sometimes it would seem that perhaps those in surgical specialties are more willing to do things without evidence than those who are in neonatology or pediatrics. Maybe, right? So this could be a role. This could be a role for a neonatologist as part of all this, to say, by the way, if we have no proof that this is beneficial, then it's either being done as part of a trial or it isn't being done.
So we'll point out to all the surgeons watching on TV that was Mark who said that.
It's too bad this time I'm sitting in the right one with my name. Yes, last time wasn't so bad. It was somebody else's name. But I do think that the place for randomized trials is central. But Elena makes the valid point that it's hard to do. I understand that. But this is a question that needs to be asked openly and honestly every time we want to try something on a fetus or a baby or a 10-year-old where there's not good, solid evidence that it's going to help. Maybe, in this situation, it's still a reasonable thing to try. But the conversation should begin with, what do the data show?
So, Norm, first David Woodrum and then you, Norm.
I can't wait to tell my wife tonight what I am, fetal pediatrician, no longer an aging neonatologist. But I have a perspective that's a little different than a lot of the discussion about maternal-fetal conflict. I do counseling of pregnant women, and I work with my colleagues in maternal-fetal medicine, and the dilemmas that I see, and perhaps it's a limited biased population, is the exact opposite, is that pregnant women will do anything for their fetus, anything that we suggest gives the fetus a reasonable chance, which leads to the second discussion, which is, and now we're giving them all these choices, or we don't even have to give it to them. They go to the internet, and they come in and tell us what are the opportunities for them to go to Nashville or Philadelphia or San Francisco and have this experiment done. So my concern is, for us as attempting to do ethical consultation and counseling, is how do we negotiate this?
Norm?
I just wanted to go back to the fetal surgery thing. I agree with Jeff. It's hard in our country to get state action, and in the absence of a single-payer system, to regulate these issues. But there are things that professional organizations can do, and one recent salutary example is the current controversy over surgery for MS. So there's a surgeon in Italy who did a series of patients with multiple sclerosis who he diagnosed some flow problem, a venous flow problem in the brain, and did an intervention that he claimed had dramatic results. A surgeon in the US reportedly duplicated this. And patients with MS began clamoring to have this diagnostic study done and surgery done, and there were willing providers. But in very short order, I mean in less than a year, a large, increasing number of neuroradiologists began to decline doing even the diagnostic procedure, annoying some of their surgical colleagues. And then the surgeons and the radiologists got together. And long story short, there's now an NIH-funded trial to look at this in a prospective way that was put together in rather short order. So it's an example in which professional organizations can get together and say, wait a minute, let's not let this very risky, invasive procedure get out of control.
I think
Okay.
just if I can say a word on the MOMS trial, what's interesting is to see the disability groups' views on this. And it's a bit unique, called the open maternal-fetal surgeries. As soon as you open, you risk fetal demise, you risk prematurity, you risk death. And the disability groups with spina bifida or with other problems are saying, in order to save us from a little bit less disability, you're willing to sacrifice our life, which is not maybe the same thing as the other innovations. So I think this just adds even more murkiness and grayness in this zone.
Gray is the color of the day. Okay, next question, please.
Mark Pine from San Diego. And perhaps you've begun to answer this, but even aside from whether or not the fetal surgery procedures are efficacious, let's say for the sake of argument that it's been developed that they have, Dr. Gates alluded to the learning curve involved in doing these things successfully. And we just recently got ranked in San Diego in U.S. News and World Report, and the hospital administration met with us, said, well, congratulations, and we want you to be ranked higher than Seattle. So, how are we going to do that? We think that you ought to consider developing a lung transplant program. And, the pulmonologist in me was saying, well, sure, we're as good as anybody else, and there's no reason why we can't do this. But the amateur ethicist said, well, what do we have to offer that the two programs that are already very successful in California can't provide? That this is something that's not limited by the number of people who necessarily should do it, but by the expertise and the donor population. What, if any, ethical considerations really ought to govern the proliferation of programs for which there isn't a huge numeric need and to where the acquisition of expertise requires years and years of experience?
I guess I'll start with that. No, I'm not the apologist for fetal surgery. I remain very skeptical. I think you're talking about lung transplant. It's true across particularly surgical interventions. I don't know that we have a good way of govern. I think there's a lot of information for those who do want to understand how to manage the learning curve. Some of this came out of the whole story with laparoscopic cholecystectomy that some of you may have remember. When they went from doing large incisions to little videoscopic procedures for taking out gallbladders, there's a common condition with pretty squishy indications. a lot of centers started doing this, and adults were dying from complications as people were trying to learn to do the procedure. And there what happened was that there were some agreement on credentialing and numbers that people needed to do under proctoring before they could have the credentials to operate independently. And those numbers were somewhat evidence-based, based on number. Usually for a lot of new procedures, robotic GYN surgery is one I'm more familiar with now. One thinks of getting up to 40, 50, 60 cases with some proctoring before working independently. So I think there are norms out there. I hate to rely on the tort system to keep us in check, but I think that I'm getting shaking heads up here. It doesn't stop people. I sort of feel like it's a little mouse on my shoulder sometimes. The learning curve is a very interesting phenomenon, and doing something for fame and fortune versus doing it because there's a real human need to be spending those resources. Resources is another aspect of this. It's a very good question.
Maybe as a Canadian who the government decides everything in our country, there's pros and cons. So we can't open an NICU anywhere at the middle of nowhere just because we're good in ICU and we've got money. But there's more moms who get prenatal steroids and more moms who deliver in tertiary care and ICUs. So we have the bad of the system and the good of the system. So the government in Canada could decide that there's 2 centers and that's it. And the people who know the government might get it in their center, and there's other things that comes with that, but maybe government are solutions and also have risks involved, but sometimes solutions.
Okay, next question, please.
First, I'd like to thank the gentleman for the great question. I think the issue there is because we can, should we? But the driver in San Diego is cost and profit. And I think we can't lose that. And there is a problem. I see a tremendous ethical problem, so thank you for the question. This is a difficult issue for me to frame, and it kind of crosses over from the ethical to the legal, and I wanted to hear the panel's comments on it. The little contract and litigation law I know and that I've been taught talks about a standard of reasonableness. And as I listen to all the slippery slope conversations we get into, what the panel has brought up so beautifully, I keep on going back to the standard of reasonableness, which I understand is a legal issue. But also the standard of reasonableness also speaks to capacity, which is an underlying issue around autonomy. And I was wondering, in the framework of what we've talked about, of everyone's talked about, and I've heard the word of the panel come out, reasonable decision. How do you see this standard of reasonableness in this terribly polarized, highly commercialized population that we now deal with? And I'd like to hear your thoughts on that.
Anybody?
I'm glad to start a little bit. I think we need to be careful that reasonable isn't informed by attitudes and biases and prejudices that aren't supported by fact. Many people across the country will disagree about who should be parents, what the nature of families should look like, how many should be parents, what their sexes, ages, combinations should be. There should be 2 parents, there should be just 1. And so what seems reasonable to someone will seem unreasonable to another. And so I think, I understand what you're saying, but I think it's important to guard against the creep of reasonableness based on belief as opposed to reasonableness based on fact. And then, the other, you bring up the notion of the law and reasonableness. I'm somewhat fond of saying that ethics is about, in some sense, what's right and wrong, and ethics is not the law and vice versa. And there are plenty of things that are potentially legal that are unethical. So important to keep that in mind as well. And I've stunned my colleagues into
I think, I think that that's beautifully said. I would add that we sometimes have a hard time determining exactly when day turns into night. So, in like fashion, we sometimes have a hard time determining exactly when reasonable turns into unreasonable. Nevertheless, we can all agree that at 11:30 p.m., it's night. And there are some things that we will all agree on that we can all agree that while it's awfully hard to describe, and Jeff is exactly right, nevertheless, there are some things which we'll say, that's unreasonable. And I do think that should play a role in our thinking. Very hard to flesh out exactly how and when, but I do think that it's a good point. And at some level, that needs to play a role in our thinking. And some things will be unreasonable to, if not all of us, damn near all of us.
Okay, next question, Jeff.
Hi, Jeff Sconiers from Seattle Children's here. And I'm just a dumb lawyer, so I don't necessarily track all this stuff with the clinicians. It's interesting to me that the discussions this afternoon fairly quickly moved to clinical case decision making. And I was yearning, and maybe this follows up on what Mark was just saying, yearning for more in the way of principles. I understand that if we get more information about fetal surgery or some other currently unknown areas, it will be clearer what the decision making ought to be. But I think you've set up during the course of the day a number of scenarios where there just are fundamental conflicts between values. And I'm wondering if you think that there are principled ways to address and resolve those conflicts, which I think goes back to what John Lantos was talking about this morning, whether there are some fundamental principles at work, or is it a case that it all just depends? And all we can do is sort of talk among ourselves, and whoever's in that room in that conversation has to get to the end of the conversation with a decision.
I'll start with one area where I think I see us putting a little bounds on the gray area, and that is using the concept of suffering more intentionally when we talk to families about their fetuses, future children's, babies, and talking about suffering as something we can all agree should be avoided. And I think it is a place where people really can agree, because I don't think anyone thinks suffering's a good thing, and then it gives us a shared goal to figure out how we approach. One example.
Maybe as a physicians, I think we need facts to establish, in order, for example, to say over 50% is a good survival. I'm just inventing 50%, it could be 75. We need to know if it's really 50%, and we need to do good science to show that it's 50%. So right now, for example, to know the outcome of babies at 24 weeks, we need to know how many moms go to tertiary care centers, how many stay in the primary care centers, how many are offered a C-section, how many babies die in utero without offering an intervention, how many get a neonatal consult, how many decide to intervene versus not intervene, how many die in the delivery room, how many go to the NICU, and who dies. And at these 7 steps, you can die. And most of what we see in NICU papers is who dies after being admitted to the NICU, and that's what we give parents. So the weeding process, which is a grotesque word, but where you can decide not to intervene before, that's all scientific. So I'm not saying that all the moral dilemmas can be solved with science, but you need good facts to make decisions and not say, oh, this is 20% survival. In the Epicure study, 24 weeks, it's 20% survival because they count the kids who died in primary care settings. Well, that doesn't count. I mean, of course, if you have a car accident and you're left at the side of the street, you'll die. So when you present parents, you need to give them good facts. And I think that's what you're trying to say for fetal surgery. You need to do good science in order to at least have numbers to decide afterwards if 50 is good or 40 is good or 20 is good.
David, do you have anything to add to this issue?
Two different groups come at this, in my opinion, they come at it from a different angle. we come at it from that perspective. And unfortunately, I think that's, in my opinion at least, that's a lot of our counseling, not only prenatally, but postnatally in the intensive care unit. And we live and die by these numbers and by the science of accumulating these numbers. Once again, I don't have data and I don't know how to get the data, but most families that we counsel don't do it that way. They come at it from a totally different perspective. As I said before, if I talk to a pregnant mother, and some of the people in the audience have heard me say this ad nauseum, they'll say, you know, when I got pregnant, I quit drinking coffee, and I gave up my daily glass of wine, took my vitamins, got the right amount of exercise, slept at night, and I had a lot of strong Braxton Hicks contractions. My husband and I gave up having sex. I've done everything in my power to make this work. And now are you asking me to give up and do a 180? So, and they don't care about the data. And they don't care if it's a 20% chance. For them, that's 1 in 5. That's pretty good. So I think, yeah, we have to have the data and we have to use it, but we have to be cognizant of the fact that that data appeals to us, but it doesn't appeal to most families.
Okay, next question.
Hi, my name is Pat Healy, and I step up here to represent all the other pediatric surgeons that aren't in the audience here. I was waiting to see who was going to step up before me, but I'm very interested in all the commentary and data and talks. I've really enjoyed being here. One of the reasons I went into pediatric surgery is because it had such a breadth to the field, and there are definitely stereotypes about surgeons, and I would guess I was stimulated to stand up actually by Mark's comment about data-driven, evidence-based advancing the care of clinical decisions. And that is an issue that, all stereotypes aside, we actually struggle with in surgery. Any procedural specialty, how do you actually move the field forward when there have to be pioneers out there that are pushing the envelope? There is no data before there's these pioneers. In surgery, you think about liver transplantation, kidney transplantation. Those are standards now that were definitely experimental in the 60s and 70s. Fetal surgery, I think that what we see is, and in laparoscopic surgery, minimally invasive surgery, the benefits of the fetal surgery program may not turn out to be in the long run from a surgical care perspective due to treating, or may not result in treating fetuses with these congenital anomalies. They may be introducing nanotechnology or microtechnology that can be applied in other fields. The challenges for doing multi-center randomized controlled trials is that in surgery, there actually is individual variation in skill or in technical ability, patient selection. So your outcomes can't be reasonably assumed to be the same in different environments. So, but I agree that it is a challenge. I don't know that it's true to actually say that neonatologists are that much better at evidence-based medicine all the time. There's more example of more opportunity for that, but there may not be. I don't know that that's universal. What I wanted to say was that the challenge we see, and I would second David Woodrum's perspective on this, is that when we see a patient for prenatal counseling with a diaphragmatic hernia in our center here, we know the data, and we believe actually in the academic or bigger model of how do you advance the field, how do you learn about fetal interventions, how do you take better care of or try to advance the care of these children with fetal anomalies. that there should be some structured approach, and maybe a few centers are, maybe that's the best model, where there are dedicated centers of experts, and the rest of us need to wait and see. The challenge is that institutions, hospitals, market, it's a business, and there are, individual surgeons who seek opportunities that maybe are given a great opportunity personally to build something and be rewarded for it. So, and patients come into prenatal counseling saying, well, why shouldn't we go to San Francisco? We just need to go to San Francisco. They'll fix it. Because when they get on what they see on the internet is just what you said, fetal treatment centers. So we find ourselves discussing the role of fetal surgery as a non-practitioner, and it almost feels like we're trying to convince them not to have what is already accepted as the best treatment, and it's not proven to be so. I think the broad public understanding is that, yeah, why isn't everybody doing it? And they don't see the risk. So I'd be interested to hear your sense on just the conflict really between marketing and data, evidence-based data in terms of making clinical decisions.
Could I first, thanks for being a good sport. Second, if I were to suggest to you that neonatologists are really better at this than surgeons, you'd know that, come on, you're absolutely right. We joke about neonatology being evidence-free medicine. We've got good solid data for like surfactant and 2 or 3 other things, and we think we're scientists. But the fact of the matter is that we face, even in a non-procedural field, although neonatology, we can say, is a semi-procedural, certainly not on the scale or the level that pediatric surgery is. So it is true that multi-center studies take on a different feel. One can still randomize within each center in a multi-center study to account for that to some extent. But nevertheless, we face the same issues in neonatology. Should we give nitric oxide to preterm babies? Well, we could just do it, because it seems like a good idea, and they're doing it someplace else, or we could say, no, we've got to take part in a trial. Otherwise, 20 years from now, we're going to be doing it and still not know if we're actually helping or hurting here. And so we do it. I appreciate your thoughts on this, and you're quite right. And I mean, what I told the guys between the break is that the stereotype is the surgeon who wants to go forward, and there's also the neonatologist is sitting there in the bow tie saying we can't do it till we have 6,000 more data points, and we never want to move, and you guys are trying to fix the problem. So I think that together we can work through these. But I do believe that as best as possible, we have to do these randomized controlled trials. And as much as the families may not look at this on a data basis as much as we do, I think part of our job is to help them understand that that's important. If they found somewhere on the internet that somebody's doing coffee enemas for diaphragmatic hernia, and they say, why shouldn't I go to X city and get a coffee enema for my child? It's our job to tell them, no. And we're not going to start doing coffee enemas here because they do it someplace else. If someone wants to do a trial of it, we'll talk about that. But that I think it's our job to actually share with them the information and let them know what is and isn't a proven therapy, understanding their desperation. But that's part of our job in counseling them, is to tell them. Some things, if seem like a good idea, they make sense physiologically, but there are no data. Some things have been studied and shown to be of no value, and some things don't even make sense physiologically, and I think that that's part of our job to counsel them for those. As far as the marketing issue, I don't know if Elena wants to address that, but I mean, I'll address it briefly. The easy answer for me to sit up here is to tell you that you've got to forget about the marketing issue of this, and you've got to tell people the truth. And sometimes that means that they're going to go somewhere else. But the alternative is to do something that either is inappropriate medicine or that we at our place are not qualified to do. And this is not just about fetal surgery. This is about, in pediatrics, this is about opening up an ECMO center when there's already one 2 miles away that's barely got enough cases to keep competent. Do we really need another one? Or does that just mess up the care in both places? It's about all sorts of things. It's about opening up another newborn intensive care unit when there's one a mile away. Do we really need another one? And this was Annie's point about in Canada, where there's a bit more control, they can be a little bit more intelligent about this. But I appreciate the situation you're in and that you're looking at this thoughtfully and trying to negotiate these waters. But I think in the end, you still have to tell people, the truth about what's been shown to work and what hasn't.
I'll just add, I think your comments were great. So thank you for speaking up about all those issues. On the marketing, I think, speaking as a physician that works in a large medical center, the medical center holds the resources, and as the physicians, it can be sometimes difficult to push back against those strategy guys in the medical center who want to build this, that, or the other program for some goal that's not necessarily about health care. And I think we have a responsibility to do what you said and sort of push back and say this isn't a good idea. Another thing in terms of the randomized trials, I'm not optimistic that we're ever going to be able to do randomized trials of surgical interventions for a lot of reasons. I do have optimism that some of the decision science and biostatistical understanding that's evolved over the last 10 years or so may get us closer to be able to look at the data that we can collect to understand what it means. Meta-analysis, for example, is a tool that's come up in the last 20 years that I think has been pretty informative at putting together a bunch of not so great data and getting us something that at least, well, bad data yields bad data, but I think some of it's useful.
Okay, one last question, and then we'll stop and finish with our last talk. So, Marcia.
I guess I would really rail against the idea that a broad public understanding of something that's beneficial or not beneficial is a reason to do it. There was the little letter that came out in the New England Journal in 1996 about the public perceptions of CPR and the fact that most of their information came from television shows and front page of New York Times and Newsweek stories and the U.S. News and World Report, where they talk about face transplants and CPR being effective and other things like that. So I really think that we are accountable to know the data, to collect the data, to inform the families. And I think that I actually disagree with David's assertion that the families should be allowed to just make whatever decision they do based on emotion. I know that that comes into play. But I think that we have to see the decision-making process as a process. It is not a one-time conversation, that there are all kinds of things that wash over the families as they're presented with their situation, with the data. The way we present the data, if we give it verbally as opposed to in a pie chart of statistics, is much less effective if we do it verbally versus in a visual way. So we have to take some responsibility for that. I mentioned earlier about videos and really seeing what the situation is that they may be choosing for themselves unknowingly. And I think just throwing them into that without giving them that kind of information is really profoundly unfair and inappropriate and unethical. I think as well that they really need some empathy and they need some time to discuss with their extended family, with their religious advisors, with their community members, what they're going to be doing given the data that we provide to them, the hard data that we might know. And I want to invite either Michelle or Jen, who are the grandmother and mother, respectively, of 24-week preemies who are now 3.5 years old and still on feeding tubes, but bright spellers and mathematicians, if they wanted to maybe comment about the idea that they should be cast to the wind in the decision-making, or whether they need some more guidance from data.
This is what happens when you talk to somebody very quickly at coffee break. Actually, I'm the grandmother. My daughter is here with me. We're probably the only non-medical people in the audience today. It was well worth the price of the ticket to get here. This has been absolutely phenomenal. The question was, would we like the statistics or just be kind of left to the wind, I think is how I heard it phrased. Actually, as the family, we need both. And what I heard from Dr. Woodrum was something a little different, that I was hearing it's not that the parents want to ignore the statistics, it's that we interpret them differently. When you tell me that my 24-week preemie boys have got a 20% chance of life, it doesn't mean anything to me. It's a statistic on a large population. I want you to tell me what's going to happen to these boys, not a population of a similar set of numbers, what will happen to these boys. And that's the one thing you can't tell me. You can't give me a promise of how all this NICU experience is going to come out. So as a parent, since we can't be told how the story is going to end, What I need to know is some of the facts, the statistics, the numbers, give me the raw data, but then give it to me with empathy so that I can make the emotional decision. It's not void of the numbers, it's in partnership with it. So I'm not depending on either one. And the one piece that we get from you, because we stare and take in every little nuance of the medical team, what I'm looking for is an element of hope. I'm not looking for a promise. I'm just looking for something that tells me that the 20% is worth going for. Might not get there, you're not promising, but I might make it. So that's what I took out of it.
So thank you very much for that. There's a lot
I think
can
we
learn from
agree.
that. Yeah.
I think we agree.
Yeah.
You and I agree.
We're going to actually build on that perspective that you just offered. But first, let's thank all the panelists.